let's go back to our patient. Let's get some more information about Akiro. We did our physical examination, tachymucous membranes. He had good bronchovesicular sounds. They were unremarkable. His urinary bladder was very turgid and elicited a pain response from him. There were no overt orthopedic abnormalities on the primary survey, but he did have an erythematous penis. We obtained a minimum database, Paxil total volume, total solids, lactate, venous blood gas, CBC chem. And what you can see here is mildly elevated Paxil volume and hyperproteinemia, probably most consistent with relative erythrocytosis, dehydration, etc. Our lactate is high. We never want to see it above 2. We have a metabolic acidosis that is being contributed to by the lactate. We have a neutrophilic leukocytosis without band, so no left shift. Our manual PCV correlated pretty closely with our calculated hematocrit, and our platelets were fine. And we have severe azotemia and hyperphosphatemia with a normal calcium, mild hyperglycemia, most likely a stress response, and hyperkalemia at 8.2. So we modify our problem list, and hopefully you're all very comfortable taking these new problems with the existing problem list and coming up with your diagnoses. Akiro has urethral obstruction. He has a grade 4 acute kidney injury that is certainly post-renal in nature, pre-renal in nature, and we always have to prepare the owners that there may be an intrinsic renal component. We won't know until we treat him and see what happens to his azotemia. And he is presented in late decompensatory hypovolemic shock. Why late decompensatory? Because he had the triad of death: hypotension, hypothermia, and bradycardia. So when we have patients like Akiro, we need to heat them up, okay? And I know I am preaching to the proverbial choir here when I talk about and mention prevent the hypothermia in the first place if you can, but I still think it's always worth remembering why we need to avoid it as much as possible. That's why we've been discussing it. So utilize your technician and nursing team and your assistance teams and train them to look for these heat-seeking behaviors and heat-conserving behaviors in our patients. Maybe the patient that is burying itself under towels isn't just trying to reduce anxiety and hide from you because they're nervous being in a foreign environment. They may be trying to get warm, okay? So don't take that type of attention for granted. We have different rewarming practices. We call them passive surface rewarming, active surface rewarming, and active core rewarming. So the way I simplistically explain it is passive rewarming is taking the towel off the shelf and putting it directly on your patient. Active surface rewarming would be taking the towel off the shelf, throwing it in the dryer to warm it up for 5 or 10 minutes, and then taking that warmed blanket and throwing it over your patient. Okay. We also use our forced air blankets, our bear huggers, our hot dogs. A lot of people will use warmed water bottles or warmed rice bags. Okay. What we're not going to use is heat lamps or electrical heating pads because we need to avoid thermal injury or the risk of thermal injury. And very rarely, but still worth mentioning, is the potential need for active core rewarming strategies like warm water enemas or infusing warmed intravenous fluids. Every once in a while doing lavages of various cavities or organs like the urinary bladder or the stomach.